Thank you very much. What a build-up. I'm not sure I'll be able to deliver on that, but thank you very much, Pavel. It's an absolute pleasure to be here. I'll just give a brief sensory description. Sorry, I'm post-COVID and a bit croaky. I'm white, cisgender woman, medium height, late 50s, blonde hair, which is totally natural, of course. And so it's just lovely to be in Oxford, isn't it? What a beautiful, beautiful place. So in the Faculty of Medicine and Health, where I've led much of our Athena Swan work over the past 10 years, we've been really keen to use the skills that we have within our own academic staff. Not everybody wants to join committees, but you know, we've got so many different skills and types of expertise to bring together. And so I'm just going to talk today about a piece of work that I did with my colleagues whose names are up here. And I've put the QR code on because clearly a systematic review can be a little bit dry to present, so I'm not going to talk an awful lot about the methods and so on. So if you wanted to have a look at the paper, that's how you get it. Okay. So, a bit of background. In medical schools, there's a real concern about how we sustain our clinician-led research and teaching. That's because we've got a declining academic workforce in medical schools. Around 80% of our clinical professors are men still. Around 25% excuse me, of clinical academics are aged over 55. So there's a problem with recruiting and retaining clinical academic staff. And as now the highest proportion of medical undergraduates and medics graduating are women, clearly we've got to do something to recruit, support and retain our female clinical academic staff. So Athena Swan activity within medical schools, there's been a huge focus in medical schools, partly to do with Dame Sally Davis's edict in 2011 about getting silver awards. Mentoring is one of those things. It's almost obligatory to have some kind of mentoring in your action plan. And some colleagues and I thought about mentoring, and we tried to pick over what it was, partly because we'd done another way of looking at gender equality interventions and identified mentoring, but thought, well, what is it? It's such a broad thing. How do we know it's actually doing what we hope it should be? Is it actually going to address some of these concerns that we have? Okay, so we're not the first person to have thought about this. It's, you know, nothing new under the sun, as they say. So this question has been asked before. So Sam and Jack and colleagues in 2006 produced a systematic review of addressing this question, which is that we're addressing the same question but in a slightly different way. And they identified, so 2006, mentoring is perceived to be an important part of academic medicine for women and men. Evidence to support reduction of inequalities, however, was not strong in 2006, and they called for better evidence base for EDI and mentoring studies, addressing the contextual issues and using cross-disciplinary approaches and more rigorous research methods. So such a lot's happened in the world of Athena Swan and EDI since 2006. It seemed an appropriate time to be asking the question again. But we wanted to take a different point of view. So in medicine, many modern medical interventions are what we call complex interventions. That is, activities that contain a number of component parts. There's potential for interactions between those parts, and when they're applied to a target population, they produce a range of possible and variable outcomes. And you've only got to think about the COVID vaccination program, which indeed is a very complex intervention, to know that you know, it's really quite difficult. And we considered mentoring to be a complex intervention. Number of different parts, interact, how do you know, address different target populations. And very much, if you're thinking about a complex intervention, you're always asking, if it's in the medical world, you know, how does it work? Who does it work for? How does it work for them, and in what circumstances? Because only then can you target your medical intervention to most effect. So that was our starting position. Mentoring is a complex intervention. We agreed on that. Do we know what works, for whom, in what circumstances, and how? And that the graphic there is just a picture of the book where I got the citation for the 3 different key aspects of complex interventions. I hope you can see this. This is we use these a lot also in considering medical interventions, and they're called a logic model. And all they are really is you start at the end, you look at where you want to go, where you want to be, and you work backwards in a logical sequence. What do you need to do to get to that point? So this is kind of a general process, but we could think of it in relation to mentoring. So the long-term effects are we want it to be effective in relation to those issues that we've talked about, cost effective, of course, implemented in the real world, and we know how different things that are, laboratory based or clinical studies, how they actually pan out in the real world. It must work there. It must change practice. It must demonstrate some sort of visible progress. Improves health. Well, instead of improving health, we'll be thinking about improving the retention, the recruitment, the retention, the promotion of female clinical academics. Sustainable. You don't just want it to be a one-shot thing. It needs to move onwards. And reduces research waste, duplication. And then if you work back, you think about all these things that it has to be to do that, where you actually start from, things like understanding the context, what's the theoretical, what's the evidence that you've got already, even before you get your intervention. And that's from O'Cathane's guidance on how to develop complex interventions. So if you think about mentoring as a complex intervention, you can see that there are many component parts that perhaps aren't always thought about in as much detail as they should be if we actually want to assess their effectiveness. So in our review, basic standard stuff, where the papers were from 2006 onwards, which was the last review. Our eligibility criteria, so we looked at formal mentoring schemes in academic medicine, so we didn't... There's so many different manifestations of mentoring, but we were looking at papers that provided all these formally organised academic career support outside line management over an extended period of time, and the outcomes were reported, otherwise there's not much point doing a systematic review. So another element of assessing health interventions is to use some kind of a framework. So you want your interventions, if you're researching them, to be replicable if they work, of course. And so we use something called the TIDIA framework, which is often used, a template for intervention description and replication. You can see down the left-hand side the why, what, who, how, etc. modifications, adherence and fidelity, which you would do in a health intervention. And then we thought about that in relation to mentoring. What is that going to be? What's the rationale, the goals, or the theory behind this? Materials, training, how you select the mentees and the mentors, right through to recording participation, frequency of meetings, and so on. And there's the citation for the TIDIA framework. So I'm skipping right now to the findings, really. I think that's possibly what you'd be most interested in. So we did indeed find that we were able to characterise mentoring as a complex intervention and break it down into those component parts. But we couldn't for each of the papers, so it was really rather kind of messy in that way. For example, very few papers referred to a theory or that was underlay the intervention, so recognising that these were for gender inequality interventions, no real reference to evidence or theories of why gender inequalities may exist in the first place, for example, which I think is really quite interesting. Oops, I'm not sure. There we go. Okay. However, because it was so varied, so disparately reported and so different, and people use mentoring in very different ways, we were actually unable to do what we wanted to do, which was to synthesize the research, the elements of the research. We would have liked to have done some elements to see what works in those components, what's the most effective thing about mentoring. Because there was a lack of standardized approach to defining the intervention, the delivery, or the outcomes. I think I need to... There we go. Literature still very dominated by observational studies, surveys, that kind of evaluation. Weak research designs, for the weak research designs to answer the questions. I'm not criticising the actual research. Lack of RCTs, so really interestingly, there was hardly any comparison groups. So there's supposed to be gender equality, but they weren't comparing men and women, and they certainly weren't comparing, absolutely, in the literature that we looked, a kind of a look at intersectionality. Did it work for black women, for example, disabled women? There's nothing like that. There was no strong evidence for addressing the things that we might think are important in gender equality in academic workforce or any workforce. Reducing the gender pay gap, improving promotion, retention or academic performance. But importantly, there was no good evidence that they don't. Okay, so if we were thinking about medicine as mentoring rather as a medical intervention, I don't think the NHS will be paying for mentoring. There is just not enough good evidence of the benefits or the harms, potentially. So, okay, so you might think, well, should we stop mentoring schemes because they are expensive, resource intensive, certainly in the NHS context where the clinical academic mentors will be coming from. And if you think about extending to other protected characteristics, there are very few black clinical academics, very few senior black clinical academic women. Do we expect them to mentor our black students, for example? So we really have to think about, is this worth doing? As I said, there's no strong evidence for benefits, but there's no strong evidence for harm, although things can go wrong in mentoring interventions. The work, as we've talked about so often falls to female colleagues. So mentoring schemes need quite a lot of administration support to keep going, almost inevitably falls to our female colleagues. And there is the view that mentoring is actually fixing the women, not the system. We should be looking at what the promotion criteria are. We should be looking about what it's like to work in academic medicine as a woman and not try to fix people by mentoring. However, we also know supportive advisory work relationship can be really helpful. I'm sure many people in this room, if not everybody, have benefited from that. And there was some evidence in some of the studies that were better that there was some suggestion that they could improve retention, promotion prospects and actual academic outputs as well. But the trouble is that those well-run mentoring schemes that have this kind of research associated with them are often in organisations where there is generally quite a good focus on gender equality. So how do you know it's the actual mentoring? How do you know that it's, or is it something else? So we're still at that point where we have to think we need more specific interventions. We should be thinking what works, for whom, in what circumstances, inequality interventions as in anything else, because there is cost associated, time, resources, and if things aren't right, then you're in danger of reinforcing inequalities or worse, creating new ones. And thinking about, is it mentorship that somebody needs? Is it coaching towards promotion in a particular environment? Is it sponsorship linking into more opportunities? Or is it actually opportunities for peer support and having a more detailed and nuanced understanding about what works, when, for whom? And of course, here we are, we need for better quality research on these, but I would also say that there's need for, going back to the logic model, a need for theory-informed interventions as well. You know, I think Polly talks about theories of change. We've got such a lot of kind of evidence to use in our interventions in relation to EDI, and we're just not using them effectively yet. And so I think this is a fantastic conference and an opportunity to be thinking about that. I think that's me.